When I have patients or clients that come in with anterior knee pain, a lot of times what I'm looking for initially is I'll just have them stand and look at posture, right? I'm looking at their position, that Q angle, right? Their position of their knees, sometimes their patella mobility, how that patella moves, right? I'll look at their gait. So I'll assess
Yeah,
them
yeah.
walking, right? Looking to see if there's anything where I can see a restriction in that mobility, either at the knee or at the ankle or at the hip. And then on the table, right, we're doing assessments of moving that kneecap, right, looking at how that moves because that actually acts as a lever for your knee. So if that's not moving or it moves too much, that can
Hmm.
affect some pain, as well as just looking at muscle tension, right? Doing some tests. I sometimes will do some testing depending on the client for strength testing and everything, but also just looking at muscle tension and how that's affecting their ability to move and function and range of motions.
Yeah.
So,
I wanted to ask one other question, just kind of right on cue with that, right? So you say
mhm.
you'll do gait assessment. You're typically doing, do you do shoe on or shoe off, or do you do both?
So typically I do shoe off because I like to
Hmm.
be able to see how the foot moves.
Yeah.
If for whatever reason somebody's not comfortable taking their shoes off, or they have some other dysfunction where they can't, we can do it shoe on. I just don't get that as much of a read on that
I
ankle and foot
Yeah,
mobility.
I fully agree. Plus, like, when you have the shoe on, you can't really see how that big toe's behaving too.
Exactly.
So, like, you can really start to get a better gauge if somebody's really walking, and then you realize, like, oh, you get to the end and you basically pivot your foot because you don't have the ability to power off through your big toe. And if you're pivoting at the foot, like, no wonder why your front of the knee pain is right there because you
Hmm.
load it right at power off and everything. So,
Definitely.
this is all the stuff that's valuable assessment. That's great that you do that. Full disclosure, I don't probably do as much in that in practice as I
Hmm.
should. It is so valuable. I don't quite do enough of it though. When I do assessments, I like doing a lot of assessments on the table. I actually always say that the number one thing we do, it doesn't matter if you come in with big toe pain or if you come in with hip pain, if it's lower extremity pain, we're actually clearing the lumbar spine first. You would be surprised the amount of times that somebody comes in and they say, it feels like I have a hip pain or knee pain, and we actually assess the lumbar mobility, see how much restriction is happening there, and then sometimes we do just McKenzie exercises for the lumbar, and that pain gets like 70% better. And then it was the realization that that was never actually knee pain, that was full lumbar pain. And maybe no wonder why you went to this person for 4 weeks and had them hit your knee really hard and you didn't get better because it never was your knee, right?
Hmm.
Um, that's still kind of more of the exception than the rule. What we'll typically kind of see is that it's kind of like a co-treat situation where, yeah, you got a problem at your knee, and it's still a really good idea to do some lumbar spine work because that's where the all the main nerve roots that make up like your sciatic nerve and your femoral nerve are coming from the
Right.
lumbar spine. So even if it only improves the knee by 5 to 10%, why wouldn't we take that 5 to 10% of improvement? But usually with the knee, I'm looking right at the hip. We'll get like a lot of hip baseline movements. We'll get the knee. Because once again, sometimes there's only so much movement you can get at the knee. When we do like a block and try to test the extension at the knee, it's a really subtle joint play. Plus, even then, too, getting like heel to butt. At least the nice thing when we're assessing knees, though, I even jokingly say this in practice, is we have two of them. So in theory, the other side is normal, and it at
Hmm.
least gives us an idea of like we at least have a little bit more of a better idea of a control and how your knee should be behaving. But trying to test out those ranges of motion, I'll do a handful of orthopedic tests just to make sure that we're not, in fact, dealing with like an ACL potential injury or an MCL. And if that does happen, then I'm usually sending them up the hill to Mount Nittany and say, like, go talk to orthopedics first, make sure they don't think you ruptured some sort of tendon. I want to clear that first, right? Um, but then I like also doing the functional muscle tests, like really testing like the two divisions, like the three of the main divisions out of the quad muscles, like the iliopsoas, hamstrings, and calf divisions. It's amazing how much weakness will turn on. And then we apply McKenzie Method exercises. So frequently, not a hard fast rule, but if we're thinking something more like a younger student athlete or somebody that's like 40 and under and they say front of knee pain, they're typically going to do really well with the repeated McKenzie extensions at the
Hmm.
knee. So opening up that knee. And it's amazing how sometimes just 15 of those and you take a muscle that melted down like warm butter and it's back to strong and everything. So that then gives the patients all the empowerment for how they need to keep getting better outside the office, and it guides us exactly how we're going to manage them in office.